It's 4 o'clock. Welcome, everybody, to the May Indian River County Hospital District formal meeting here. I'm glad to see everybody here, and we will start with an invocation from Reverend Dr. Joe LaGuardia.
A few minutes ago, I was talking about one of my parishioners, the late Haynes McDaniel, who served on this board many moons ago, helped start the new hospital when it moved from the old location. Sometimes things like that remind me of where we've been and roots us in our community, it reminds us whom we serve. And the other thing I thought of is we all had a busy day, so I'm going to start with a moment of silence just to take a breath and transition and then close with prayer. So let's pray. Lord, in this time, ground us, give us a sense of peace, allow us not to break under the burden and weight of business, and let us be joyful in remembering the legacy that we've inherited and the legacy that will be left. Whether we make a difference today or perhaps plant a seed for tomorrow, may it give a generous, joyful, life-giving service to this community. I pray that each person here will use the discernment and wisdom and guidance necessary to meet the needs of our neighbors and our friends and our families, that we ultimately might serve you. Amen.
Amen. Thank you. Pledge of Allegiance. We'll start with the consent agenda. If I could hear a motion for approval of the chairman's meeting minutes dated April 17th, the regular monthly meeting minutes dated April 18th, and a May disbursement of
$1,841,287.53.
So moved.
Second.
all in favor?
Aye.
Okay, thank you. Just a couple things. We had a board meeting of the hospital yesterday, and I think everybody is well aware that Dr. Peter has left for family issues, so we wish him and his family the best going forward here. Dr. Rick Rothman is the interim person. Dr. Rothman has been with Cleveland Clinic since 2014, so he was here before the transition, and we're happy to have him. He's a real bright young man, I'd say. And so he's got his hands full right now with that too, but we're happy to have him. Just high level, we did talk about, what I can communicate here from board meetings and what I should not. But high level, what we went through is obviously the challenges. Colin goes from the Florida perspective. They talk at a high level of how Florida is doing overall, and then get very much into the detail on what is going on at Indian River. So they talked about the challenges in that. They spend a lot of time on safety. I thought it was an interesting bit of information to say that their safety error reporting has increased by 50%, which is a good thing. They are encouraging people to report safety incidences. They celebrate them, the people who do that, as safety heroes. And I think that that's a really, really good thing that they do. So the fact that it's increasing the reporting doesn't necessarily mean it's getting worse. It just means that people are more comfortable to be able to report it. So. Spent quite a bit of time on quality, ironically, with what you're going to talk about, their leapfrog stuff today. We spent a lot of time talking about quality, everything. They go through every kind of measurement there is, from ease of care to mortality. They talked about leapfrog. They talk about all of the different quality measures that they've gotten and what they need to do about it. I don't know if you've heard, but they started a hush campaign in the hospital, and that was because they got feedback from patients that they couldn't sleep because it was too noisy during certain times of the day and night. And so they've started a big hush campaign between 2 and 4 p.m. in the afternoon and between 7 and 10 p.m. at night, so that people make a choice of being more quiet so that patients can actually get rest. I thought that was a really, if you go in the hospital, you'll see all these signs that say hush on them, so that's what it's for. I also thought it was interesting, they do talk about, of course, you know, they're working on the new ED department, but 90% of their patient surveys come through people who came through the ED. I thought that, 90%. I thought that was an interesting statistic too. So the other thing I didn't realize is that as far as maternity patients and that, I know we used to send high-risk maternity patients to Orlando or down south or all that. They don't send them anymore. And I guess, I know you sit on, you know, that board, but I guess I didn't realize that we brought in people that, so that high-risk patients stay here. So I didn't know if the rest of you knew that or not. The other thing is the care at home, and again, I'm not sure if any of you have been through there yet to do that. But they are now at over 1,100 patients, and their average length of stay that they keep them is a little over 3 days versus the average 5 to 6 days that stay in the hospital. So that's turning out to be a very successful program.
Say it again. They keep them in the hospital?
In home. No. This is in the home.
In the home.
They have hospital at home, so they monitor them 24/7 and everything else. But their length of that they have to stay there where they're
in the home.
In the home.
In the home.
With that kind of care is on the average 2 to 3 days less than if they were in the hospital.
And how many people do they have?
Over 1,100 patients have been through this program now.
In what period of time?
In, I believe it's the last 7 months. Now that's including Martin patients too. They're doing that because they can do them, but the hub is here. So. I would encourage you to go take a tour of the hub because it's very interesting. These nurses are very, very dedicated. And they stand on treadmills while they're talking to their patients, the nurses do. And yeah, it's a whole different environment than what you're used to. But it's a very successful program. So anyways, that was pretty much what was going on with the hospital board yesterday. So District Council, Jennifer.
Alrighty, thank you. It's been another busy month at the district. As always, I've responded to questions of each of you as they've risen and remain available to each of you. We're continuing to review the annual deadlines and deliverables due under the lease with regard to the Cleveland Clinic Indian River. Have spent a decent amount of time this month under the leadership of Trustee Karen Deagle, working with our committee, of which Karen is the trustee, looking at properties that could be used as a potential detox and sober living facility for the community. After one property located in the city was ruled out over zoning restrictions, the district has continued its focus on the property owned by the Children's Home Society located in the county, and we are expecting a response to our offer that was put in sometime, hopefully this week, maybe even by, today's Tuesday, maybe even by tomorrow, Wednesday. They have a board as well, so it's a bit of a process, kind of like things are for our board to get a response. It's not like sending an offer to a singular owner. So we're working through and navigating that, and I really hope to have something to bring before you, maybe even for our chairman's meeting tomorrow. We're continuing to monitor the past legislative session, House Bill 7013, which was signed into law on April 26th, and it's going to go into effect July 1st. It's going to affect the district in a few ways. It's important to understand that this new law limits a trustee, a board member's service on an independent special district to no more than 12 consecutive years. Service prior to November 5th of 2024, however, does not count in determining the 12-year period. Second, the boundary of an independent special district may be changed only by general law or a special act. And third, beginning on October 1st, each special district must establish goals and objectives for each of its programs and activities. And by December 1st of each succeeding year, publish an annual report on its website discussing the goals and objectives. and the goals and objectives the district did not achieve. So those that we achieved and those that we did not achieve, and we'll be working with the district staff to make sure that they are aware of what they need to do and any questions they maybe have to comply with that new requirement. We also have a fantastic new website, so I'm sure that we'll be able to facilitate this new requirement through that. We're also still kind of working on negotiating what to do with regard to the Human Services Building and considering other options regarding that. And of course, there's been some circling discussion about working with the hospital on potential future uses of the 82nd Street parcel. Those issues are still circling and things that we're continuing to work on, and we'll be bringing back to you for further discussion. Any questions anybody has for me at this time? That concludes my report.
Okay, hearing none, we will move on to our financial review. Michael?
At the 7-month mark into our fiscal year, I am delighted to again report the hospital district's financial condition continues to be very good. For an overview of our finances, let's turn to the last 4 pages in the financial report stapled together that you got in your packet. 4 pages from the end, you will find this month's investment and cash report prepared by Mr. Isley. The top of that report shows you that at the end of April, the district had received 92% of our budgeted tax revenue. Just as a point of reference, that's about, actually it's 4.7% behind the tax revenue receipts that we had received at this point last year. But this is not an issue of concern at this time. That gap will close over the rest of the fiscal year. Section 1 of that report gives you a look at our U.S. Treasury bills, totaling $9,350,263, and the right column can show you how those are laddered to mature monthly through November of this calendar year. Section 2 shows that we have a little over $5 million in the Florida Fixed Income Trust. That's basically a money market, and it continues to earn us 5.27% interest. Section 3 shows the status of our local operating accounts, which we're holding $3,454,768 at the end of last month. This all totals, as you see at the bottom of that page, to holdings of $17,885,881. I will note that our investment holdings for this month, in comparison to the prior month, went up because this report includes the $3.8 million received from the sale of our property to VNA. I'd ask you now to please go to the next page, which is page 1 of the year-to-date versus budget report. This first page begins the detail of all program expenses through April, and on the right column you see that at the 7-month point, if it were an even monthly expenditure of budget, expenses would be at the 53.8%. As you scan down through our funded programs, as always, over this and the next 2.5 pages, you'll find some programs behind that benchmark, some are ahead, and some are right on the mark. You will note, something we've talked about at the last 2 monthly meetings, that the 2 LIP programs, that's the local income payment, at TCCH and Whole Family Health, they still show at $0 or 0%, but those invoices were received and were paid earlier this month. So next month's statement will catch that up. And if you turn to the last page of the report, a third of the way down, you'll see the totals for all program expenses through April. They total about $8.4 million and are at 51.8 of the budget. At the bottom half of the page, you see where it begins to track our administrative expenses. Now, several of these are high, a couple are even over the budgeted amount, but we've talked about those particular ones, and they're actually referenced in the cover page to this section in the last couple of monthly meetings. You'll see that total admin expenses are at $837,869, and they are at 71.3% of budget. Combined admin and program expenses together come in at $9,272,186 and are at 53.8% of budget. Is it 53.8 or 53.1? Thank you, 53.1. As a point of comparison, at the end of April last year, our total expenses, admin and program combined, was at 51.4. So we're a little bit ahead of that. And again, we had two very expensive payments made for LIP. Fundamentally, that concludes my report, Madam Chair, but I'd be happy to answer any questions, if I can, that the trustees might have.
I had one question related on the second last page, related to the percentage of available cash invested at 81%. Just masking, is that a good number, or do we try to get most of the money?
I'll actually let Frank speak to that.
Yeah, I can speak to that, Dr. Cooney. We had, with the transaction for the VNA money, typically I invest as soon as I get money in the account, and there's a basic threshold of funds that I leave in there, just necessary to pay operating expenses, and I invest everything else. This month, I didn't invest it in time. However, going forward, that typically won't be the case.
Well, the stock market or investing is a tricky business, and it's up, but if it goes down, do you adjust that percentage?
Well, we're safe with the Treasury, so what I'm trying to do is maximally invest every dollar we have to make sure we're able to pay our monthly bills with just enough in reserves, but I want every single dollar that we have invested. And with the Treasuries, we're safe. It's consistently paying 5+%.
And the money market,
Everything's
liquidity is
paying
right there.
5+% for us.
We can tap it at any point in time.
Correct, the PDP, so the Treasuries are available, but I'm specifically laddering the Treasuries based on what I know the cash we will need. I have in the PDP. The PDP is immediate liquidity. We can pull it out whenever we want.
And we are restricted in what we can invest in.
Correct.
Heavily,
So that
Correct.
it is not
by
at risk
statute.
much.
Right, there's certain limitations because they're
Yes.
tax dollars.
Yes.
Yeah.
And in fact, later on today, I'm assuming you're going to give approval to a document that even contains a section that talks about what we can invest in, and it's right out of the statute, so.
Right. Okay, any other questions? Thank you, Michael. We'll move into our executive director report.
Sure. Thank you, Madam Chairman. Just a few updates, and there's several things on my list I'm going to defer to tomorrow for a larger discussion. One being the Human Services Building and 82nd Avenue or more the Human Services Building and VCOM. So that information's in our packet for tomorrow, and we'll have a detailed discussion regarding that. Women's Sober Living, I'm not going to say anything else on. I think our council covered that sufficiently. We have a couple items, Independent Special Hospital District Performance Review. That's due to Tallahassee in the month of June. We've completed that work with our consultants, BJM, and we've done everything we can to review that. We feel we have a very good document, and we'd like to submit it. So what we'd like to do is ask for that approval to submit that. The submission would come directly from BJM. They would submit that to Tallahassee. I don't know, Dawn, do you have anything else to say on that?
I really don't have any other comments other than Trustee Westcott did have a question on the draft version, an error that needed to be corrected. We have received a final bound version from BJM, and I know that one particular error wasn't there because I did start going through that today. I'm just taking, probably my 70th look at the report, but I'm just gonna, go through the final report and just make sure everything is good before we give them the obviously with your blessing to submit the report. Everybody had a copy of that, and just look through it again just to make sure everything is squared away.
So that said, Madam Chairman, would you be comfortable moving forward to say, okay, let's take a vote to submit it with assuming that ensuring that these corrections,
That now, or it's down in
No,
unfinished
whenever,
business?
correct,
Yeah,
correct,
it's in
whenever.
unfinished, and we'll move forward with it.
Indeed. So, impact campaign, we've completed 2 projects that we've been trying to complete for the past several months. Very happy with the outcome. And, you know, Caitlin's been working with our local firm to get the website completely updated, and we're live now with some great information, and we will be adding more information. Inclusive in that will be, not starting in October, but before October, our dashboard, so we can look at the metrics we're going to track and, you know, be compliant with the new reg. But our annual report too. Caitlin, anything else to share on that? Caitlin did a fantastic job working with
Very much so. It really looks
our local folks. So,
Yes, I thought it was excellent, and I wondered what the distribution would be, because I've distributed to some people who I thought should have it, and they thought it was terrific.
thank you for that.
Yeah, so I did also send out, I'm sure all of you guys received it as well, an email announcing the new website. That also went out to a whole bunch of people in the community, different leaders of the various organizations, just a whole long list of people. So, and I've gotten some good feedback as well. So everyone is aware that the impact report is on the website. They can go look at it, how we're trying to highlight the success stories as well. Really kind of put the focus on the organizations that we're working with as well.
I might suggest, coming from a world where you run a database and you keep every name and every email address of anybody you have any communication with, because we used to fundraise that way. We don't do that, but it would just be a valiant effort to start compiling. We've got community leaders galore. We have organizational members galore, not just our own, but others. I mean, part of the new us is getting the word out there, and I think, you know, good, bad, or not, indifferent, we need to push out everything we've got just to help people know more about us. So that's a time-intensive kind of thing, but I think we really ought to just begin to make an effort to.
I think that's a great idea. I think, you know, we could always borrow a list from United Way, perhaps. I mean, someone has a pretty comprehensive list that.
I don't think they can do that, but who knows? Yeah,
Okay, fair enough. Another nonprofit that has a, you know,
but there are ways, absolutely there are ways.
They're really restricted to be able to share that kind of.
okay,
But they may send it out themselves if you provide the.
Bingo, that's just what I was gonna say.
fair enough.
There are others,
There's another way to get at it.
there are others
The
that can
Community
share.
Foundation would be another one. They would send it out.
Exactly.
Okay,
So
great.
it's easy, it's not easy to pull it together. It's an easy process, what you've got that lists that you can revisit time and time again when the messaging is appropriate. We don't want to overuse that list either.
The other one would be the Chamber of Commerce, both here in
businesses, yeah.
Sebastian. Absolutely.
Absolutely. And I'm sure Dory would be supportive.
Yeah, that's a great,
One
yeah,
that I suggested Frank send those to, and I would
Indeed.
actually see a list. Maybe we could help you identify who you didn't identify.
Yeah, yeah, that
It
would
was
work.
excellent.
it was well
Easy for
done.
me to give you job to do, ladies, but it's just one of those things that,
Well, we'll look into that and we'll follow up at the next meeting on our distribution. The other thing that's interesting to look at, just for the public, is, and it was an education for me to walk through the history since the first hospital in Indian River County, and just pulling the history together from our archives and understanding and walking through 1932 on, and how the first hospital to the growth of the district. It was pretty interesting. So. Okay, so as long as we're on Caitlin, let's stay with you. So we had talked about a 7-month pilot for our Beyond SNAP program. So I've asked Caitlin to give an update.
Yep, so we're continuing to see more and more people. So this month, or April, we had 60 families and 118 individuals served. And that is 24 more families than last month, and then 43 more individuals. So it's definitely increasing. I talked with Wendy over there a little bit, and she said they're gonna start marketing it a little bit more with like some social media posts. They're also informing everyone that goes to their grocery program that these are services that will be available. And then I think they're also talking about creating a short video, probably to put on social media to get some awareness out. So they are gonna start marketing a little bit more for it.
That's good.
Great, thank you for taking that on, Caitlin. And I've got two more things. One is, I had mentioned at the last meeting with the transition of leadership at Cleveland Clinic. Our local hospital obviously is a big part of our healthcare delivery system, and I wanted to be sure, as the leadership team at Cleveland did as well, that we had just an ongoing forum for communication. So I started my weekly calls with monthly calls with Dr. Rothman. And he's really receptive to be able to address or answer any questions, any uncertainty, anything that needs clarification. With a new leadership team, it's important that, they're our hospital, so it's very important that we have an ongoing collaboration, and they're very willing to work with us, answer questions. Dr. Rothman's been fantastically responsive and helpful during this transition time. So I just wanted to put that out there. And the last item is, kind of the elephant in the room, because it applies directly to us and our responsibility with the hospital district, is some potential big changes ahead for our healthcare landscape in terms of just north of us, Sebastian River Medical Center, which is going to be sold in July. To who, we do not know. But between that sale and sale of the two hospitals in Brevard County, we're looking at a pretty big change in healthcare delivery in terms of new companies, new ways of doing things. How are patients going to react who have, let's say a patient has an elective surgery. I have a total hip replacement that's scheduled for July at a hospital I know is going to be sold in July. Could that affect where I'm going to get my care? Our doctor's going to look for new places to work. Our nurse is going to look for new places. Our patients. I have been on the phone with our team at Cleveland about this, and they stand ready to assist wherever needed. They've been monitoring this, of course. They understand the need just to make sure our county is served. But it's also going to be an impact to Brevard County to the north. So to what degree that's going to affect us, we're going to have to wait and see. But I'll make sure that I keep the trustees updated on that.
Yeah, there was quite a bit of conversation about that in the board meeting yesterday as well. I mean, they are well aware of what is going on and monitoring it and assessing what Cleveland can do and what they want to do. So
I realize the agenda item specifically mentions for discussion tomorrow, but I was thinking, as this story has kind of unfolded, with them going into reorganization, their issue probably surrounding payment to vendors and providers and so forth. The byproduct of that is likelihood the difficulty in delivering services, and I can
Steward, right?
Yes, I can certainly understand they will likely want to be guarded about news on that topic, but we might think about, for purpose of tomorrow's discussion, just I'm sharing this with you all now, do we want to engage and reach out to them and at least open the door for communication so that if they are seeing developments, perhaps they can share with us so that we can coordinate with Cleveland Clinic and any other providers to build a safety net.
Were you saying Sebastian, to coordinate with Sebastian?
Sebastian, yes.
We've already, just so you know, we've reached out to them. We've reached out to them through a direct front door channel. We've reached out to them through a back door channel, and I've had no response. Just even to meet with them as a fellow healthcare leader for 30 years and say, let's talk about how we can help serve the community. And no one's responded.
I suspect somebody in their headquarters is wanting to be tight-lipped just so that they can.
I understand, but at the end of the day, we're
I prefer they
responsible
not,
for the
but yeah.
patients, people in the community, so we have to serve them.
I had one individual, and I don't know that this individual is typical or not of a member of the public, that didn't understand that we didn't have some responsibility for the hospital in Sebastian. Yeah, I mean, there's always, again, it's all part of who we are and getting our message out there, but they wondered what we were doing, and we had a good discussion, and I shared that, in fact, we are trying to engage, but we have a different relationship or responsibility to them, to the organization, not Much different, though, when it comes down to the citizens.
That's right.
And they understood, but it was just an assumption that they made because they never paid attention to the hospital district.
That's all for my report, thank you.
Okay.
Frank, you mentioned something in your report about dashboard and the dashboard going, are we going to see that dashboard? Because we had some pretty,
We are actually, because we have, so Caitlin and I are working on pulling together some other data, and so we'll be able to present that at our next meeting.
I just didn't want it to pop up there on the website.
Absolutely not. The trustees will absolutely approve that before anything gets posted on the website, yes.
Yeah, you got the reaction last time, so,
We've already been there.
Making sure.
yeah, I think you learned. Okay, we're going to go into our funded agencies. First is Sunshine Physical Therapy. On the agenda, we also had under new business, an additional funding request from Sunshine. I have asked Ginny to put both of those things together for, just to be more compact, I guess, and let it flow easier. So I appreciate it. Ginny?
Hello, and thank you all again. It's nice to see you. Thanks to those of you who have come to visit us recently, because things at Sunshine are changing, all for the good. I welcome the rest of you who haven't seen us lately to please come by. We've had an excellent year, and we're walking into another fantastic year already this year, seeing quite a few more patients, building our therapy staff, and building some financial sustainability, which is nice for everybody to hear. Where would you like me to begin? Mid-year report?
Yeah, let's
just
start with
a
the mid-year
update?
report. Yep,
Okay.
let's do that.
We provided you with a mid-year report that showed our progress specifically towards the measures that we had promised. You'll see that in the first two, we did have some, we hadn't met our goals in some of our PT programs. I will share that our PT program does suffer from patients who don't follow their home exercise programs. So we are working towards that, towards improving that, and that's part of the reason why we had some issues. We do have some challenges with insurance funding. It does give out after a certain number of visits, and many of these patients require more therapy than their insurance will support. So that is where we are trying to raise more funds to be able to offer some financial support for those clients who require it. But the third outcome measure, we see that our speech department had some challenges reaching their goals, and I did want to speak a bit to that. Speech is notoriously difficult to measure. It is, as our department head and one of our SLPs says, it is at the top of the pyramid of everything that has to happen to be able to support specifically children with communication. If there are behavior issues, if there are some OT issues, if there are sensory issues that are affecting a child, then they can't necessarily benefit as much from their speech therapy because it is just a bit more of a challenge. I think that was one of the notes in there, was that we're dealing with kind of the secondary issues that affect the baseline, and those are hard to track. So we have started an interdisciplinary effort. A lot of this has to do with socialization of the kids. So we have our OT team and our speech team treating concurrently. It's not a co-treat. They're working with two separate kids, but it allows them to work on similar goals that the two children are both facing, while they're also being more socialized, and so they get that communication as well. We're anticipating that that interdisciplinary approach is going to bump that success on those measures significantly by the end of the year. We just started that last month, and it's already showing tremendous success. So as for our mid-year itself, I do have to share with you that we've seen an increase of 15% in total visits between January and April of this year over the same period last year. We've also seen a 15% increase in our cost per visit since we came to you last year, and that is just the reality of trying to keep our therapy team and meeting some of the needs of those candidates who are coming in to the industry. So between January and April, we provided over $230,000 in Medicaid support after Medicaid reimbursement. So that was our total loss for the first 4 months of this year. We've been reimbursed by hospital district for 91,740 of that. That was what we had available. And we right now have no more funding for adults, no more funding for peds, and about $16,000 worth of remaining funding for our ARC special needs program. Thus, I have come to you in hope that you would support the balance of this grant period, which is the additional 6 months moving forward. I sent you a letter earlier, I think in April, related to this and requested an additional $125,000 to help us through the balance of this year. We do have funds that we have raised to be able to supplement that. So while we're expecting that we will require more funding than that, I want to put skin in the game myself and not come to the hospital district for the whole nut. And then, of course, we've placed a request for the next year's funding as well.
Part of the letter also said you'd like to take $10,000 out of ARC, but if you're already down to $14,000, is that still part of the request?
Well, when I
switch that
spoke
to
with
adults?
Jennifer, I said, no, we're going to back that out. However, things at ARC have changed as well. And this just happened last week. We've met with the leadership, and our therapists also believe that a more socialized experience for the ARC clients is going to be far more beneficial for them. Many of them have challenges focusing on one-on-one therapy. So the concurrent treats and group opportunities is where we're going to head. And I will say that thankfully we've received United Way funding for those groups. So we won't require hospital district funding for the group sessions. We will still have some one-on-one therapy, but I think to release that $10,000 would be a good decision. I think we're going to be fine.
Does the ARC not put in any money for the therapy services?
They do not. Mm-mm.
Just one of your statistics was really, it's I had mentioned it to you before, but for an established practice to have an increase in volume by 15% is unusual. Did somebody close? I'm just curious if there's something happen in the community that...
And that's Medicaid specifically. Yeah. We have seen an overall increase, but part of it is because we have increased the number of therapists we have. So we have more capacity.
I see.
Mm-hmm.
And so it's 15% increase in number of visits, not number of clients?
Correct, visits.
So clients are staying the same, but you're seeing them more often?
And we're seeing more clients.
Okay.
Mm-hmm. Although I do not have that number.
And
I figured you would ask a question I wasn't prepared for, and that's the question I'm not prepared for, but I can get it for you.
Is there any particular area of growth? Is it peds on, the speech therapy? Is it where you're seeing your greatest pressure coming from? What demographic?
Well, it is across the board, but peds certainly is our much higher rate of Medicaid. And we have increased our OT. Our waiting list still sits in speech. We will be bringing 2 additional speech support SLPs over the summer.
So the last time your wait list was
done.
Mm-hmm. Now you have a wait list.
We have a wait
on
list
for speech therapy.
For speech therapy. Yeah.
It's expected. It's obviously just a lot of job security for you in that department.
well-
Unfortunately, with the masking and the experiences of
Yeah.
home isolation and so forth,
Yeah.
it's just going to grow.
Well, the beauty of being able to say we have eliminated our wait list means everybody then is going to refer to us because we don't have a wait list. And like I said, we are getting more support in the speech department so we can start working that wait list down again. It's not nearly where it was at all, but it exists.
Jenny, can you break down your staff as far as your number of PTs?
Sure.
And how they separate the adult to pediatric?
Of course.
And then go all the way down it, so start with your PTs. How many do you have?
We have 4 PTs in the adult area. 3 of them are DPTs. We have 2 PTAs, and we're getting ready to bring on another. She starts next Monday. We have a new adult OT coming on board tomorrow. So that is the
That's
adult.
one OT,
One OT for adults specifically, yes.
OTAs?
2 CODAs in our PEDS department, but none yet in adults.
And your speech therapist?
We have, well, and we have 2 OTs in PEDS as well. So we have 2 OTs, 2 CODAs in the pediatric department. We have 2 SLPs and 1 SLPA in speech. We have 2 part-time DPTs in our pediatric PT program, and we are seeking full-time and seeking a full-time PTA for PEDS right now.
And then your PT techs, how many?
We have 5, and we are preparing for a 5th.
So-
6th.
So, being in the business,
Yes.
PT techs in the private sector disappeared a long time ago, because you couldn't afford to keep them for what they could do. So that, to me, is quite a bit. Unfortunately, we have to change pillowcases ourselves.
Right.
You know, that's just the way it works. But it does reduce your payroll. Your payroll is really high. I mean, obviously, that's one of your huge expenses.
Yeah.
So, considering the amount of patients you see versus what private facilities do, you're really staff-heavy compared to a private type facility. So, to me, you could work with that a little bit more, and maybe, and we all know reimbursement, whether you're a nonprofit or you're a private, reimbursements are going down. They're going down in all aspects of medicine. And so, yes, you have to pay your professional staff, but again, I know in the private sector and other small clinics here in this county, the therapists they're not getting quite what they used to get. They're paying for their own continuing ed and those type of things. So I just think that looking at your staff still could use some work.
Barbara, I've got a question with that. The clients that the for-profits are seeing, the privates are seeing versus what Sunshine is seeing, are they the same, or are they picking up more of the disabled, or?
I mean, just at my facility and 2 smaller facilities that I know that therapists that work there, I mean, we write stuff off. We may have a Medicare with a Medicaid secondary. Well, we just have to eat the secondary, the 20% that Medicare doesn't pay. We eat that. So it's not like the nonprofits aren't seeing some of this as well. You know, a lot of those.
That wasn't my point. My point was
Okay.
the time that it takes. So if you're seeing, if Sunshine Therapy is dealing with clients from ARC, maybe some developmentally disabled, I don't know if the private companies are seeing the same level of care that's required, and would that be one of the reasons that you have more staff? I don't know if that's.
It could be. I mean, you know, a stroke patient, a CVA patient is going to take more work than probably your rotator cuff repair patient. Okay, that's true. But again, looking at the orthopedics and what we used to offer and able to do with our patients, we've had to figure out a way to do that with less. And so it's not, I mean, I've been doing this for 42 years, and what we used to be able to do versus what we can do now is a big difference. And it's stressful.
Barbara, can you quantify, in other words, you've heard the staffing level, a differential, in other words, they're off by 10 or 15 or 20%, whatever? I mean, do you have the ability to quantify? Do you give us an idea?
Well, and I'm probably looking more at the adult side versus the pediatric side, because obviously that takes more, I get that. But on the adult side, can you tell me offhand a percentage of the type of patients you have? I mean, like ortho versus neuro versus?
Well, I could defer to my colleague behind me, but I would say that we do see quite a number of vestibular patients. We see quite a few ortho. We are starting to focus on some other areas of need, like special needs adults, and they, like you said, do require a little bit more support, not just to assist in the actual therapy, but transfers and things like that do require more than one person. So they're helpful in a number of ways, not to mention assistance with some of the administrative piece. I mean, we do have quite a bit of scheduling, cancellations, refills that go through, and they help with that as well.
And
So-
at the risk of seeming feisty, I'm really not, Barbara. And if I'm hearing you correctly, to know definitively, you need more information. Okay.
But I do appreciate the observation, Barbara.
Is there, I don't know if you would even know, but is there an industry standard in terms of how many techs you have for X number of, you know?
I can't have techs, I can't have them, because I can't have techs do any type of patient care, they just can't, it's not.
Well, I'm not talking about what they do or don't do, and I based on the limited experience I've had.
It depends, let me just jump in for a second. It depends, because it all depends on, if you have a sports med orthopedic clinic, it's completely different than running a clinic in a different setting where most of your patients are gonna be vestibular, they're gonna be neurological, they're gonna be, it all depends on what your mix of patients are. If you're back-to-back, you know, ACL reconstruction, shoulders, knees, hips, it's completely different setting than that.
That's not a cut and dry.
It's not clear. There's more information.
That's fine.
For clarity.
What is, in light of the additional funds you've been able to obtain, what is your current ask in order to finish the year? Is it still the 125?
125.
Okay.
If I might, Madam Chairman, related to that, if you look at Michael's report, they spent October through April 24th, $209,000, which was almost $30,000 per month. So there's 5 months left, so they need $150,000 if they're spending at the same rate. So it seems to me their additional request of $125 is appropriate. I'd like to move forward and make a motion that we accept that recommendation.
Second.
All in favor?
Aye.
Aye.
Any no?
Can we deal with, and I don't think this is a big thing because we do it with other agencies, she'd like to take some of the ARC money and use it for other adults. It's already designated to her agency.
Yeah. Anybody have
Does
an
that
issue
require,
with
yeah, I don't know if that
10,000?
requires a vote.
No, I don't think so.
It may, because it's a change of use, but that's up to you. Okay.
It's a reallocation, and at this point, I
You're
think
good.
what we've
All
said
right.
is a reallocation can be dealt with between friends.
You're good.
Well, thank you all.
Okay? Thank you,
Appreciate
Jenny.
it. Okay, yes, absolutely. And please, I am always open for questions. Anytime you want to come by.
I think you might want to follow up with Barb, though.
Yeah, I will,
on
because
that.
I would like to have further conversation with you. Yeah, absolutely.
I think it would be good.
Yeah.
Maybe have some of that
It's a
oversight.
very valid point. Thank you.
Thank you, Jenny. Appreciate it. Next, we've got Jennifer, We Care Foundation.
Hello, everyone. I'm so honored to be here. I have so much to report about our little organization. We have been very, very busy these past 6 months with our continued restructuring. I've taken a lot of the notes that you all have shared with me and guidance and suggestions and have tried to work to apply them to collecting our data, which I hope I did a relatively good job representing, because we've never really had much of anything, so we got to start somewhere, right?
Yes. You had a big hill to climb.
Yeah, and it's been a great. There's been a lot of benchmarks that in a lot of boxes that we've checked between going through strategic visioning and bringing on a donor database and starting to be a little more organized with collecting the data and hoping that it is what you're looking for. Most recently, we've now found a home, so we now have administrative offices, which we'll be moving into next month. Which is exciting for We Care. And most recently, we have been given a wonderful gift. Athena Health has given us a free license to their electronic health records. So no more Excel master, Excel sheet. Yes, and this is enormous for our organization. As you saw, my many numbers and lists, this is huge. And so hopefully by the turn of the new year, we will be onboarding in our new home with new data and new records. So yay for us. The ship is finally turning.
That's great. That's great. Where is your new home?
Downstairs underneath you guys.
Oh, okay. All right.
Yes. So, and we have, and you know, when the planets align, they really shine on you, because our little organization had been searching for the perfect office just for our administrative needs. We were starting to outgrow where we were in our little home at TCCH, and we had a wonderful physician give us a majority of our office furniture, because he was closing one of his offices down in Stewart, so we did a big, huge move. I mean, because the expense of that for our little organization was difficult. But I'm so happy that the pieces are starting to come together.
Good news.
I know that in our report, our numbers for ophthalmology were probably not as where we would expect them to be. While we're serving in a lot of numbers, there has been a great deal of turnover in the billing department of our 3 partners. And I try and be patient, and I'm trying to hold a lot of hands, because they don't understand We Care and how we work. And so working with the physicians, their new billing departments, and it's been 2 full turnovers in one department. Our representative has had major surgery over the past winter. So the services are being given and provided, but we're just not getting that billing. So I am trying to work closely with each one of our providers to get that in, because I know you want to see that, and you want to get the providers paid as well. As Jenny mentioned, which it was sort of good to hear, but not in a good sense, because that means that we have great need, is we too are seeing higher level requests. More people are coming in with referrals, and we are up 11% and 10% compared to last year. So again, we're saying that there's a need for this care and that there aren't resources.
Jennifer, what type of services are there? Has it increased, or what?
Well, you know, the biggest, our biggest area right now where we're seeing quite a bit is cardiology. And I must say that what it seems to be, when I talked to Dr. Screeden about it, it seems that in his evaluation, a lot of it has to do with COVID. We have a lot of people who are doing CPAP machines, deeper testing, exploratory. These people are coming in with a lot of problems, and so we're just seeing more and more people in cardiology. Gastro is also a big part of our program. I think, I just think that awareness is also starting to be on people's minds, and so I think they're, when they start to have problems, they are seeing their primary care physicians and coming in. It runs the gamut with us because we're specialty care, and I would love to say that there are trends, but I would say that the trend that I really see mostly is cardiology right now.
I noted that you had 33 referrals for ENT, and then the note that came on the last page is our ENT partner will only see one WeCare patient
I'll tell you, that is, so one of the challenges that we have is that we have some providers who will give and give and give and give and give, right? And how lucky we are that they're willing to do that. And then we have some providers who put very tight parameters. And they'll only see one WeCare patient a month, or our podiatrist partners, while it's difficult to find many people who will see what's nail care, and you think that that's something that's a basic common thing, but people who don't care for themselves, who have diabetes, that is a common problem, and a lot of podiatrists don't want to mess with it. And so trying to find a provider who's willing to do it when you have all these people coming to us for the care, it's a vicious circle. So and we continue to try and reach out to other providers in the community. Dr. Baker does a great job for us, and Dr. Mackett as well, trying to find other providers. And I think that a lot of the challenges that these other providers are faced with is that they're overrun in their own offices. I'm sure you all have tried to see a specialist at some point in this community. If you're not on concierge, you're waiting months, weeks. And so for a WeCare patient to try and slide into someone's very busy practice, it becomes even additionally difficult if you have a provider who is unfamiliar with us or is just starting out with us. That I don't want to say level of commitment, but it's just they don't always get us, as you know. But we continue to try and look for solutions to the problems. Another thing that we have seen as a trend is that while we have a number of people who are coming in with referrals, I have a large number of people who are not following through. They either don't show up for their appointments. They're moving. Their track phones have died. We are constantly chasing, and so it was really quite interesting that out of my 98 ophthalmology referrals that I received for the first 6 months, 20 of them, people just didn't follow up with care. And we give people chances. We'll call them, we'll email, we'll try and find different ways to communicate. And after a few times, if they don't respond back to us, we're limited because we are only,
Come to you in the first place, like if they're.
So many times, majority of the time, they come to us through one of our primary care partners. It would be Vicki. TCCH is our largest partner in care, Whole Family, Cleveland Clinic. Sometimes we'll get them through other providers in town, but for the majority, those are the three partners in care that people come to us. And I just think that some people I think that they have a difficulty time navigating the system. They don't have the wherewithal, and we have to hold their hands through the process. Like there's almost a lack of education and understanding. I think they're afraid of once they go through the specialty care that they can't afford then the medications, they can't afford this or that, and we try and encourage them and say, we will help you with this, but I think there's a level of fear. I think there's a level of difficulty people getting out of work. I think there are a myriad of different reasons why people are not doing that, but that is just something that I have noticed particularly this past 6 months.
Oh, Jennifer, the majority of your patients, I was trying to look at the number, coming through your clinics, dermatology and GI? Or is it spread out equally?
It's really pretty, well, I would say it's pretty spread out and maybe not so much through our clinics because we have our clinics because we don't have private physicians to do that care. So for dermatology, Dr. Brow will say, okay, let's take our 8 or 10 or 12 patients and let's just do it in, one felt swoop, as opposed to trying to fit them into his schedule. Whereas, some of our other physicians will be able to put them in different slots in their private practices. So it really runs the gamut. But if we had an ideal world, we would love to do more clinics because we just get a lot more work done and it's more efficient and effective in way of getting everybody together, managing notes, and the continued care beyond that.
Basically what I was asking.
Yeah.
I remember you used to have an orthopedic clinic and other
We-
specialty clinics out.
Well, just wait, because the vision is big. One of the questions that Jenny passed on to me is something to talk about is that where is We Care in 5 years? Well, it's more like where is We Care in another 6 months, right? Because we've been working so hard and diligent to get to where we are. But we're trending now and we're on forward motion. And coming into our offices gives us the ability to all work under one roof. So it really will make things flow a little better. I think that we'd be able to serve more people than broken up and how we have been. And honestly, with our new health record system, telehealth is an option for us. So if it was up to me, and it's something that I believe my board really sees the similar vision, is that down the road, we would love to have our own clinic again and only continue to do that specialty care because we are unique in our community. There is no one doing what we do at the capacity. And so to have a clinic of retired physicians who would come in and just, do certain specialties on certain days and be able to have, full day clinics, I think for our community overall, I think that we'd be able to serve it better. But of course, that's down the road, but we're working on today. And
The old We Care that we once knew versus the new.
I was going to talk about that, yeah.
We heard a lot about wait list. So you have a
Well,
long wait list and
excellent answer. And because of the hospital district funding, I will tell you that when you funded our part-time patient advocate, our new additional part-time person, you don't realize how bad it is until you have someone there who can really make a difference. Well, now we realize that she'd actually really needed another full-time person. We were chronically delayed in about 4 to 6 weeks in getting people qualified and processed and moving forward because we get the volume of what we get is, of course, it waxes and wanes, but it can get backed up to as much as 6 weeks, which it's not what we want. It's not ideal. But at least now we're about 10 days, 2 weeks at the most, and and we try very hard. So, but it's interesting because we have had an influx of of people who have more needs. We realize that we do actually need to add more time to this individual, but we're happy and good, and we're doing what we can with what we have. So.
So for the trustees that are new here, the frustration that we had always with We Care was, how many patients do you have in what kind of specialty? And they go, a lot, okay? and how many people do they actually get to see? And it'd be a few, okay? I mean, there wasn't the information behind it.
and they had staff.
Yes, they had a clinic and staff, and we could not get the answers, and it was an uncomfortable situation to be funding somebody that we couldn't have any data from to know that we were actually doing something, to support something. So I give you a lot of credit. I mean,
Good data.
I realize that you still have a ways to go and all that, but this is more information than we had seen.
Thank you. Well, Jenny's been very helpful. She's a great support. If I have a question, she answers it immediately, you know, and I think our visioning session really was helpful too, to get our board a little more engaged in understanding the importance and the depth of the work that we do in our community. I
It's
think.
always been a critical need in the community.
Yeah,
It
so-
just, you couldn't prove it.
So we have big things on the horizon.
Good. That's really good.
Thank you all.
Your billing issue, is this just providers that aren't sending you a bill that you're asking
It's
for?
ophthalmology, and yes, and because they have literally had a full turnover. I'm not sure what's going on in their end, but they have new people that they've had to hire and put in place. So because We Care gets special pricing on things, and there's a certain way that they process and our clients, and it's a little more behind the scenes kind of thing. I am trying to be more attentive to contacting them more regularly and saying, okay, I know you've got some people, can you start, sending us some bills?
In my workers' comp practice, I see payout ledgers from insurance companies, and I can see in the same community, certain facilities getting compensated a much better rate than others. There is an art to that, right, Vicki?
Yeah.
And I'm wondering if we might, as a service to our community, put together, find a few people that could come and offer a lunch. And for you providers out there that want to get better reimbursements, we got this guy. I don't know if that's to teach you how to do it better, because there is an art to it. And
They're trying, and we are working together closely. I try and make sure I handle these providers with a kid glove, because they're so important to the work that we do, that I want them to continue to look favorably on me.
well, and because, taking Treasure Coast as an example, those that use both private sources as well as public sources will, if we can help them, they will help us, because their ability to underwrite what they're doing is going to be improved. So, at any rate, just food for thought.
In
for
any
you.
medical practice of any kind, revenue cycle is a critical part of your business. Understanding, negotiating optimal contracts, updating your charge master, making sure that you're reconciling your payments with the allowables, all that. I mean, this is all stuff that, we all know in this industry. But this is the most important part of your business, second to patient care. So that really ideally has to be dialed in and optimized for any practice.
Jennifer, the one thing that, I love that you're tracking your patients and you've got it. The one piece of information that we were always looking for that I still don't see is, when did they actually get seen?
Well, I'll tell you, there's no rhyme or reason, because it's just based on availability.
No, I understand that,
I'm
but
sorry.
I'm saying on the tracking, when I have this 41-year-old, I assume that's what that was, or We Care number 41, okay, the patient was referred on 8/15, he was eligible a year later, 8/22/23. When did they actually
service
get service?
That should be in that spreadsheet.
Maybe I'm misreading it then. I see a referral and I see
Without looking at it, I can't tell you which column it sits in.
Yeah, this is it, but this is the ophthalmology one right here, but,
So,
yeah, it might be because the headings didn't come on. That's
yeah,
if
okay.
that follows, unless it was truncated, but trying to get it all on one.
Doesn't say.
No, it doesn't say. Got the received referral, but it doesn't say. We Care eligible 8/22. I'm looking at the first one,
Eligibility,
number
but not
41.
date of service.
I will work to better that part of, I think that in our full client, in the master client sheet that doesn't break down this, I believe that information is there. But we'll work to make it better.
okay. It just because at some point, what we were trying to understand is how long from when they became eligible to they actually get,
Okay.
did they actually
We'll
get?
work to adding that.
Thank you. I
Sure.
appreciate that. Any other questions for Jennifer? Come a long way.
Thank you.
Good for
Thank
you.
you for your
Jen.
support.
Good for you.
Appreciate it.
Yeah, good for you. Okay, so we'll move on to unfinished business.
Oh, it's written only. Sorry, I read it.
Good, because it's written. Okay. So I need a motion of approval to approve the performance review so that we can go ahead and send it, I guess, approve them to go ahead and send it into Tallahassee, is that what I'm saying?
Correct, yeah. With ensuring
With
that trustee
changes.
Westcott's, that one page, we just need to verify that page 24 has been updated.
Okay, yeah, make sure the
We
geography.
will do that.
So moved with the update.
Second.
All in favor?
Aye.
Okay, thank you. I also need a motion for approval of the accounting and financial practices procedure manual as was given to us last week, or last month. I just have one comment. This was really an excellent piece of work. And I give you and the team a lot of credit for it, so.
Thank you very much. It was a good group worked on this, Frank, I, and our volunteers on the committee.
Well, it was really, really well.
It took longer than I honestly thought it would, but it's a good finished it's a living document, as it states. But we're pleased too, so thank you.
Good things are worth waiting, so all in favor?
Aye.
Aye.
Thank you very much, Michael. Okay, we did the new business with the additional funding, so we'll go on to other business, and that would be Paul.
Great, thank you. Has everybody had a chance to look at the actual report online? Because it's a really useful dashboard with dials that show you performance areas. First, I'd like to say, thank you for Lisa at 32963 who brought this report to light. When I looked at it, I got to tell you, I was a little concerned because there's language, when you look at the actual report in red, there are footnotes, and it states that Cleveland Clinic declined to report. The hospital was asked to provide this information to the public but chose not to. And that's just curious to me. They did score a B. I'd like to see us do better. And I say us because it is us. And I found it interesting that this report came out subsequent to our last meeting. I was appreciative of the work that Frank was suggesting at the last meeting in terms of data collection, both in terms of the macro of what's going on, if I understood him correctly, what's going on in the macro in our community, and then specifically there was some mention of the hospital. And the concern that was expressed was, I'm concerned that the data we're going to get isn't going to be accurate or it's going to be problematic. And do we really have the ability, or should we collect data where Cleveland Clinic's concerned? And I responded to that, but the fact that we've gotten good data that suggests maybe there's an avenue here for us to start working with Cleveland Clinic and demonstrate to the community our role. So go over a couple of concepts. Are we satisfied with the B? I'm not. I can't imagine Cleveland Clinic is satisfied with the B. Nope, are they satisfied with the areas of weakness that they have? I can't imagine they would be. I'm not. That's not intended as a slam. It's okay, let's roll up our sleeves and get to work. And I think there's an accountability on our part to come alongside them and help and be engaged and show the community that we're interested in having a safe hospital, that the community shouldn't think, okay, I can go to an A hospital that's 30 to 40 minutes away and not have concern over certain things, or go here. I mean, I want us to have an A hospital, and I think that we play a role in that in terms of setting standards, doing some exploration, and so forth, and we have the statutory obligation to do so. In looking at the report, the area of primary concern is MRSA infections. And MRSA infections, it relates to hand washing. The other area of difficulty is communication about medications and communication about discharge. Those were below average practices to prevent errors, if you look at the report and the way that the dashboard is configured. The other area is doctors, nurses, and hospital staff. below average effective leadership to prevent errors, nursing and bedside care for patients, communications with doctors, communication with nurses. These are all people that want to do good work and are doing good work. Where I'm headed with this, I'm going to make a motion that we ask for data points, data information from Cleveland Clinic on the topic of MRSA, find out what their current plans or procedures are, and ask them to give us a game plan. So not directly telling them what to do at this stage, but my motion is going to be asking for them to account for this, because this report gives us a really good approach to what our job should involve, okay? If you haven't looked at it, it's the portion of the report dealing with performance management. I'm going to get to some of those pages that are in here, and this should speak to all of us in terms of what our responsibility. This is speaking to us as the trustees and our responsibility to the community. Page 11, there's a recommendation regarding, per this review, the district should take steps to inform all third-party vendors providing health and medical services about the guidelines as stipulated in Section 12 of the Special Act. What's good for the goose is good for the gander. In other words, we have that same responsibility for us through our statutory responsibilities in terms of the level of service and the providers that are working through, the specialists, specialties that are working through the hospital. We have that same responsibility. As a matter of fact, Section 12 doesn't speak to our partners, it speaks to us and our responsibility. So as much as this is telling us to hold our partners accountable, we should also hear it tell us to be accountable to the community. And under the performance management standards that are outlined in this report, districts must improve their focus on, this is page 56, on producing results that benefit the public, and also give the public confidence that the districts have produced those results. So it's in the plural because this is speaking to the body of special districts out there. Mosquito control, water management, the number of hospital and medical related districts in our state. It's speaking, this standard is speaking to everybody, us included. Public sector management must become synonymous with performance. Public sector. And just because we've leased the hospital to Cleveland Clinic doesn't abrogate our statutory responsibilities under the Special Act, and we need to become more engaged. What is performance management? Performance management in the public sector is an ongoing, systemic approach to improving results through evidence-based decision-making, continuous organizational learning, and focus on accountability for performance. Accountability for performance. Performance management is integrated into all aspects of an organization's management and policy-making process, transforming an organization's practice so it is focused on achieved, improved results for the public. On page 59, the need to focus, these are assessing challenges for us. The need to focus the need to focus the organization on results that are important for stakeholders. The patients that walk in the door at Cleveland Clinic are stakeholders, taxpayers. They're our stakeholders. We owe them that responsibility. So they're characterized as stakeholders in the healthcare of our community, the healthcare of our county, and it has to become a stronger point of interest for us and becoming more engaged so that we are accountable whether they like it or not, and that we are engaged in oversight of the hospital. And for whatever reason, we seem to be reluctant to do it. I brought this up 2 months ago. I intentionally, when I first came on the board, I knew that I was the odd man out, so to speak, so I gave it a little bit of time, but I've done my best as we've gone through to speak to these things, and we don't seem to be moving forward. And I felt like, you know what? this MRSA issue is a good starting point. It's an important starting point because it'll tell the community that we are engaged and we are concerned and we do want to improve things. I think that's an important message for us. The need to gain and keep the public's trust and confidence is another challenge. That's accountability mechanisms. Accountability is an important word for us, and we need to understand it as it speaks to our responsibilities to the community where our partners are concerned and where Cleveland Clinic is concerned. They get almost 25% of our budget, our grant writing budget. We've leased them a hospital, and in exchange for that, they have access to providing medical care to our community and a facility for which their obligation is twofold. One is to provide indigent care at a statutory level, which is in the teens of millions, I believe, a year, and then additionally making capital improvements of various quality over the first 10 years of the lease. Anyway, accountability refers to the obligation a person, group, or organization assumes for the execution of authority and or the fulfillment of responsibility. This obligation includes answering, providing an explanation or justification for the execution of that authority and the fulfillment of that responsibility, reporting on the results of that execution and or fulfillment, and assuming responsibility for those results. We are doing a great job where our partners are concerned that are providing care for the indigent care. We need to become more engaged where Cleveland Clinic is concerned. So with that, my motion is simply, I move that we request of Cleveland Clinic their data as it relates to MRSA infections, bacterial pneumonia, identify their policies they currently have in place, and what their strategy is for dealing with that portion, the MRSA portion, issue in the Leapfrog report. That's my motion.
Madam Chairman, I will, may. I'm familiar with Leapfrog, having spent time in that and the Joint Hospital Association at the Mayo Clinic, and I just want to point out that Leapfrog has two roles. One is a critical assessment of what a hospital is doing at any particular time, but also to improve your care in that area, for example, in infections, hand washing. And I notice here that the data provided is 2020, 2022 in some areas, 2020, 23 in some areas. So I would assume that they've already addressed these issues. They've already addressed hand washing issues. And what we don't have is comparative issues from, say, 2 years ago or 3 years ago, Paul. I understand what you're saying, that we need to be engaged. I'm just, maybe that data request you're asking for will provide that, but unless we have comparative data, at least from my perspective from previous years, these numbers aren't,
well, let me,
they're concerning, but they're, to me, not as meaningless. And quite honestly, I'm not sure that our role is to micromanage Indian River.
Well, we have a motion, so then we
it
really
hasn't
need
been
a second
seconded,
to
so
get
if it
into any
isn't seconded,
discussion.
it fails. So
Yeah, before
nobody
we
wants to
have-
second it, so be it.
Well, I don't know that they've gotten to that yet. I just want to point out we have a motion,
Right.
and then we need a second, and then we can go into discussion if there's a second on the motion for all of you.
Robert's rules, right?
So is there, do I hear a second?
And to address Dr. Cooney's observation, my motion was very intentional with that in mind. In other words, getting the data from them currently gives us current data. So I made my motion, and it failed for want of a second, so we are finished with the topic.
I will say one thing, and the information relative to what you're talking about. Dr. Sonia Peace, who I just met yesterday, is in charge of quality for Cleveland Clinic, Indian River. Knowing that you had that issue and wanted some information relative to that, I did ask if she would be willing to come talk to this group and specifically about those issues that they have. They have a lot of data. I sit in the board meetings, I see the current data, and I can tell you that when a report comes out like this, and there is something where they're not up to, and better than an average performing hospital, those areas get immediately looked at and immediately said. But that said, that's
We
only.
don't know that.
That's only me that sees that. And I think it is right that this board should see that too. So I would suggest that we ask Dr. Peace to come and speak to, not
I
just
would love that.
Leapfrog,
I think
okay?
it's not
But
at all
talk
inappropriate.
to all of the quality efforts that they have going on at the hospital. So I would make that motion.
I'd second that.
In favor of that?
Having her come and give a report, sure.
Yes?
Yes.
Okay.
And also, if I could just share that, you know, meeting with Dr. Rothman every month, he's more than willing to answer any questions from any trustees regarding what's happening at the hospital. So if you have any questions, he's committed to responding within 72 hours, you know, and making sure that there's clear information exchange, your questions are answered, and I'll share that with all the trustees. Whatever the questions are, whatever the answers we receive, I'll email everyone so we're all on the same page and informed.
But to Paul's point, I think particularly in the area of quality,
Indeed.
it would be right for us to bring Dr. Peace here and have her tell us what's going on.
Here.
Okay?
Great idea.
I did like Paul. I mean, I flagged the ones where we were below average. And the one that struck me was the hand washing. I mean, HMIRS is a bigger thing, but I don't know what not washing your hands leads to.
I mean, it's a valid head scratcher, but
Yeah.
if you, and I don't know they do, but if you're in a frenetic environment with
Yeah.
turnover and short-staffed and you know, things are going to fall between the cracks.
So
And-
it has been.
And that affects the level of service.
Really vote on that, your motion?
So
I
you have
don't
a
know that
motion
we
and a
really.
second.
Can we vote on the second motion then?
Your motion, yes.
I thought we did.
To vote on it.
I thought we did. Okay. Can I hear support for?
Yes.
that? Yes? Any noes? Any noes? Okay. Okay. Any other business? Any public comment? Yes.
We'll be brief, but this is important. We've worked with ARC now for about a year. We have a majority of kids with special needs. Katrina has started a parent circle for parents with special needs. I spoke with ARC yesterday to talk about emerging issues, and this isn't an emerging issue, but it is something that I want to shed a little light on and hope that we can figure out a way to move forward with some solutions, and that is our special needs community. 10% of the population of Indian River County is defined with some sort of special need. And I know Jennifer will appreciate this because the number of specialists in this community that are available to people with special needs is abysmal for a county like ours. ARC requires taking its individuals requiring sedation for dental down to Stewart in order to get seen. And a parent this morning talked about the fact that for her child, who's 5 with severe special needs and is medically fragile, they can either go to Gainesville or to Miami to have him sedated for dental. So she is now purchasing things online to try and take care of him herself. And it's something that I think we have the ability to help with. It's a matter of how. I just am putting this out there. I want Katrina to speak to it a bit, 'cause she is a mom of a special needs child. The other thing I would ask for consideration in future with anyone speaking to the hospital is patient advocates specific to special needs individuals. Because right now, they have no one in the hospital who is able to advocate for those who can't advocate for themselves. And so I know SRA has people who will come in and help. ARC has a number of hours that they put in that are not funded. They aren't billable but they're there to make sure that their clients are taken care of in the hospital, because often people just don't really know what to do with them, and so they're neglected. And
In the past, we've heard about an ombudsman availability. Do you ever hear a suggestion, we'll call the ombudsman, maybe the ombudsman can help you?
I think it's a little more than that. I think it's
I
just,
understand,
yeah.
but at a minimum, I would think that because we've heard about it, we had flyers here.
Right.
That it would be offered when things escalate and some of my personal experience when people come to me with issues, and I get to hear more about people's difficulties than I would really want for my community. I ask, about ombudsman, and nobody has ever offered the ombudsman that I've talked to. And I'm curious as to, do you ever hear anybody in this arena hear about an ombudsman being available?
No, I've not. I am, as Jenny said, the mother of a special needs child. He's actually a young adult now. And a majority of our parents in this community have to drive an hour, 2 hours, 3 hours for our children to have the care that they need. We have to drive to Orlando, we have to drive to Palm Beach, we have to drive to Miami-Dade. And that's just to see not just a specialist sometimes, but a primary care physician, because our primary carers may not be comfortable treating some of our special needs children. You worry about if your child has an emergency and whether or not you can send them to the hospital, or if you want to drive out of county by 30 minutes and have them airlifted out because they may get better care than they do in the county. And that's a decision that parents have to make, unfortunately. And it's scary. I have parents who are worried about the care they're receiving in their school. On top of that, you have nurses that don't always know how to handle some of these special needs kids and the care that they need. My son had a seizure one day, and I made it to the classroom faster than the school nurse did. And I had just come in for the day to pick him up. They don't always know. There is training available, but it's not always required. At least it hasn't been in the past. But this is something that is very alarming to the families. They feel that they are a minority, but they're growing in this county. We are having more and more special needs families coming to us as the county grows.
Does the school district have special programs and special needs? They must.
They do, but
All communities do.
they also get to capacity.
I see.
Right, and the challenge too is that they're aging out. There's a lot of individuals aging out of being a child. They're young adults now.
Yes, and trying to find a specialist for a special needs young adult is very difficult.
And you don't have a Shriners Hospital nearby?
No, Gainesville, I believe, and Jacksonville.
Well, those are not nearby.
I know.
All right.
And early intervention is everything. I mean, I have a nephew that had spina bifida baby, was actually in utero procedure that was done up at Vanderbilt, and had some complications postpartum and through his early stages, and he boxes.
Well, Ginny, thank you for bringing that up. And obviously, it's something that we need to be more sensitive to and more aware of.
Yeah, and I'll continue to talk with my colleagues as well. I know Vicki and I touched on this earlier today, so I just wanted to make sure I had the opportunity to share. Thanks.
Thank you. Any other public comment? Okay, given none, we will adjourn for the meeting. Thank you.
Thank you.